got it.
دكتور احمد تقدر تبدي.
نريد وي ادمت اكو صار عندنا عدد يعني لو دول دخلوا
كلها دخلت.
كلهم دخلوا؟
أي.
اوكي بس لحظه. Okay, already. Shall we start, Dr. Issam?
نعم دكتور أحمد تفضل.
Okay, good evening and welcome everyone to another session of our program, Doctors Further Education, run by the Scientific Committee of our Iraqi Australasian Medical Association, IAMA. A program we're running over the last 2 years, which is directed to our colleagues in general practice and hospital training, and also medical students in their last 2 years, particularly those doing the general practice term. Today's session is on the ENT with the two of our senior ENT surgeon, Dr. Hayder Ridha, and I'll run through a few lines of his mini bio. Dr. Hayder graduated from University of Basra in 1990. In 1994, he left Iraq to Ireland. In 2003, he finished his ENT training program in Ireland. Between 2003 and 2005, he did 2 years head and neck oncology and pediatric otolaryngology fellowship in Ireland. Between 2005 and 2006, he did otology, ear surgery fellowship in Darwin in Australia. In 2007, he worked as a consultant otolaryngologist in Labrador, Canada. In 2008, until now, he's working in Western New South Wales Hospital, Dubbo-based hospital. Our other colleague, the senior ENT specialist, is Dr. Safi Albekaa. He graduated from Baghdad College of Medicine in 1988, finished his fellowship Iraqi Committee Medical Specialization in Otolaryngology in 1996, fellowship ENT Head and Neck Surgery of the Royal College of Australian Surgeons in 2005. He's working currently as a consultant ENT surgeon at Calvary John James Hospital and private rooms in Canberra with a special interest in pediatric ENT surgery. Welcome again, our colleagues, and thank you very much for your time and dedication.
Thanks, Dr.
I will hand it over now to Dr. Hayder, who's going to enlighten us about the sleep apnea, obstructive sleep apnea. To be honest, up until the time I rang Dr. Hayder, I thought that this is a pure respiratory issue or topics, but it appears that our ENT colleagues have a lot of say in this regard. So, Dr. Hayder, the microphone's for you.
Thank you. Thank you very much. Thanks, Dr. Ahmed, for asking me to give the talk, and welcome all my Iraqi colleagues and my friend Dr. Safi and Dr. Issam. Thank you very much for all the effort you did. This is a very hot topic, and it's a topic in evolution. Every year there's something new about the sleep apnea that is being discovered. The significance of the sleep apnea is becoming more observed or more recognized, particularly here in Australia with the Road and Maritime Services, and I'll talk about this. So just I'll start with the hello, Dr. Ahmed. Okay. I'll start with the definition. It is defined as cessation of airflow of the nose and the mouth during sleep for 10 seconds or more. It's not unusual to have 20 to 30 seconds, and it is reported with the sleep study as apnea-hypopnea index as the number of apneic episodes lasting for 10 seconds or more per hour. Now, just to understand, pediatric sleep apnea is totally different entity from the adult sleep apnea, and I'm going to talk about the adult sleep apnea for tonight. An apneic episode can last for 2 to 3 minutes. You may think this is not compatible with life, but it is. It can last that long. It causes daytime sleepiness, and it contributes to cardiovascular disorder. With the prevalence of the sleep apnea now increasing, it's now going as high as 7% in men and 4% in women, and probably this is even understudied. It may be even more than that. We see a lot of people with the sleep apnea, and we never think that they would have it. Not necessarily always obesity. They could be thin people with certain jaw problems, and they have the sleep apnea. Now, this is from the Road and Maritime Services website. This is talking about the conditions of having a license for private and commercial drivers. Now, at the moment, when somebody is discovered to have moderate sleep apnea, they have a requirement that they have to self-report. Now, is this enforced? No, it is not enforced. We do not report the patients, but moderate sleep apnea requires a treatment because of the consequences of the apnea, particularly on driving, because of the chance of having micro sleeps, because of the chance of having accidents, because of cardiovascular disorder, arrhythmia, and it all applies to private and commercial drivers. People that have confirmed obstructive moderate sleep apnea, they can have conditional license based on annual review with the use of the CPAP, or confirming that the patient had more sleep studies, let's say after surgery, and the patient has no problems with the apneas anymore. The definition of the hello. Yeah. Can you hear me? Can you hear me?
Doctor, we hear you very clearly, very clearly.
Okay. Because I heard some sound there. Sleep apneas are divided mainly into central sleep apnea, where the neural drive to all respiratory muscles is absent. So there's absolutely no movement of the chest wall. This usually happens with brainstem diseases, brainstem strokes, brainstem and respiratory brainstem or respiratory center tumors. Obstructive sleep apnea is probably the commonest type that we see, and is stopping of breathing with the presence of continuous respiratory drive due to occlusion of the airway. And there is mixed apnea. Always, most of the patients, they would have a bit of mixed apnea or a bit of central and obstructive apneas. The pathogenesis of the sleep apnea, it starts with occlusion of the oropharyngeal airway, resulting in progressive stopping of breathing until the brief period of arousal that comes. Patient airway patency then is restored and the airflow resumes. Now, the narrowing of the oropharyngeal airway or the hypopharyngeal airway is caused by the suction forces. If you remember from the physics, we all studied Bernoulli and Venturi principles. The suction forces, where there is narrowing of the airway, it sucks in the mucosa and the lateral and anterior walls of the pharynx. The sleep after it resumes, and the process gets repeated for approximately 300 to 400 times per night. Usually with that, the sleep becomes fragmented and the sleep is not refreshing anymore. As a condition, this has usually to happen during rapid eye movement sleep, or what we call deep sleep. The development of subatmospheric pressure, again, during the inspiration, which exceeds the ability of the airway dilators, which are the pharyngeal constrictors and tongue muscles, to maintain the airway patency, causes the obstruction. During wakefulness, upper airway muscles tone compensate to the airway for the airway narrowing, and while during sleep this is lost. The alcohol is a cofactor and has a depressant effect on the airway muscles, and the arousal usually is delayed, so the patient doesn't wake, or the brain center or the respiratory center does not wake you up early enough. It tends to stay longer. The snoring those patients start with having snoring for some time before they start having the sleep apneas. The primary snoring as itself is not significant. It's only a social issue with the partner, but the obstructive sleep apnea is a life-threatening, and it is a serious matter, and I'll talk to you about the consequences of it. Obstructive sleep apnea, snoring without sleep apnea requires only counseling, change of lifestyle. The partner can always wear earplugs. I ask them to wear earplugs if they can do with the earplugs. There's a social matter, but otherwise they have to sleep in different rooms. Patients have recurrent bouts of stopping of breathing or choking, and the arousal usually leads to clinical complications with the sleep apnea. The main issues, the cognitive and behavioral disturbance with excessive daytime sleepiness, with intellectual impairment, memory loss, and personality changes. The cardiorespiratory effect of the sleep apnea, like increasing left ventricular afterload due to increased vascular resistance, due to sympathetic stimulation, the cyclical bradycardia dropping as 32, heart rate dropping as 32, as low as 30 to 50 per minute during the apneic episode, and tachycardia during the ventilation process. This can lead to sudden death or cardiac arrhythmia. And you will hear about people in their 40s or 50s or even 30s suddenly dying with no known reason. When this happens, always remember that sleep apnea could be the cause of this. Oropharyngeal airway usually may predispose to closure. Actually, people with short neck, they would go to oropharyngeal closure easier. The anatomic disturbance, such as tonsillar hypertrophy, even with adults, it's more common with children because of the tonsils and the adenoids, or having a problem with the oral cavity, like macroglossia, retrognathia, having large tonsillar fossa, floppy palate. All this is referred as crowding of the oropharynx or crowding of the throat. The obesity may contribute to the reduction in the upper airway size by increase the fat deposition. And believe it or not, even bodybuilders and all those rugby players that we see, they would have a sleep apnea because of their muscle mass compressing the airway. So not necessarily obesity, but increase in the body mass index, regardless of the cause being fat or muscle, is important. Now, the cascade of event is that breathing stops, respiratory effort continues, increase of negative intrathoracic pressure, increased venous return to the heart, increase in the right ventricular cardiac output, pulmonary bed vasoconstriction. The lung wants to protect itself from the increased blood flow. There's a lot of blood coming to the lung, leading to increase the afterload for the right ventricle. Then there is more blood coming towards the left ventricle. This will, the peripheral organs will sense the increase in the cardiac output, and then this will end with peripheral vascular resistance increase, sympathetic stimulation, constriction of the vessels that lead to the brain and the kidneys. Then you have also increase of the afterload in the peripheral circulation with increase of the peripheral or systemic blood pressure. Then you have the increase of the secretion of the atrial natriuretic peptide, which is secreted by the dilatation and the stretch of the atrium. It is a diuretic hormone, and it produces hemoconcentration through losing water. Think about all this is happening in the absence of oxygen. The strain on the heart is enormous, and the heart can fail during sleep, or you can have a heart attack, or you can have a stroke, or it could lead to death. Symptoms of sleep apnea, they are usually related to sleep fragmentation, morning tiredness, risk of accidents, loss of libido, lack of concentration, reduced sleep latency. Sleep latency is the time you fall asleep, the time between putting your head on the pillow to falling asleep, to falling actually asleep. This is called sleep latency. Those patients, they don't really remember. The moment they put their head on the pillow, they are in deep sleep, and then their apnea will start. The cardiovascular and the neurological risks, usually the commonest ones are heart failure, ischemic heart disease, stroke, sudden death, nocturnal enuresis. If you see a patient with potential sleep apnea, just ask the patient how many times does he have to go at night to go to the toilet in the absence of alcohol. In the absence of alcohol, usually, if the patient goes once or twice, then that's a sign of strain on the heart, and it's a sign of the release of the atrial natriuretic peptide. Now, cardiac arrhythmia. You can have ectopics, and you can have atrial fibrillation. And again, if you have, probably Dr. Ahmed knows, if you have somebody with the cardiac arrhythmia or blood pressure that's poorly maintained, think about sleep apnea. Patients that have type 2 diabetics, there's diabetes, they have strong association with the sleep apnea and also gastroesophageal reflux disease. The type 2 diabetes is thought due to a combination of increased insulin resistance because of the presence of the fat with those people, or because of the lack of oxygen increases the lack of oxygen increases the insulin resistance. Gastroesophageal reflux, again, the intrathoracic negative pressure creates, and the continuous effort to take a breath with the closure of the airway creates suction force that it'll suck the gastric acid towards the airway. So those patients can have gastroesophageal reflux disease or laryngopharyngeal reflux disease. Now, you see a patient with a sleep apnea, and you wonder whether you want to send him for a sleep study or not. Go to the Epworth Sleepiness Score, and you can score it the way we have here. And I would like, then, if you have a patient with Epworth Sleepiness Score of more than 9, then that's a sleepy person and requires a sleep study. Then there's another one. This is really good. The Stop Bang, talking about snoring, tiredness or fatigue, observed or witnessed to sleep apnea, high blood pressure, and then the Bang stands to BMI of 35. Age more than 50, neck circumference more than 16 inches or 40 centimeters, and below is the score. Then the diagnostic test is usually polysomnography, and the polysomnography is a detailed overnight sleep study. It is electrocardiography, electroencephalography to assess the brain waves, electrooculography, to assess the rapid eye movement, sleep, electromyography to assess the sudden jerk of the muscles. You can do tibialis anterior or submental electromyography. Also, the ventilatory variables, which are movement of the chest, which is called plethysmography, with the movement of the chest wall, with the airflow into the nose and the mouth, as well as the arterial oxygen saturation by pulse oximetry, which records the heart rate as well. Now, you can be wired like this, which is the technology that has been there for a long time, and this is a new technology. It's called peripheral arterial tonometry. It is detecting your sleep apnea through the sympathetic vasoconstriction. This is a new technology. It is very, very accurate and easy. Usually patients sleep well with it. Think about it, if you are wired like that versus just having something on the hand. Now, sleep apnea can, human beings can have normally sleep apnea. Up to 5 per hour is normal. From 6 to 15 is considered as mild, and that's per hour. That's apnea-hypopnea index, number of apneic episodes that last for 10 seconds or more per hour. 16 to 30 is moderate, and more than 30 is severe. The management of primary snoring, as I said earlier, it's a social problem, mild sleep apnea, no requirement, no treatment. If you have comorbidities, somebody with mild sleep apnea and significant comorbidities or hypopnea or significant oxygen desaturation, that will be upgraded into moderate apnea, and probably they need to be treated with CPAP. Now, if the patient does not feel, if the patient has mild sleep apnea and he is quite symptomatic, there's no harm to start the treatment. The treatments, I'm going to go to the next slide. The treatments, CPAP is the gold standard, believe it or not. That doesn't look very satisfactory. It is actually the gold standard of treatment. It is the Rolls Royce of the treatment. You can have a nasal CPAP like the first slide on the left, or full face mask, or you can have nasal prongs, which is the one on the right. The oral appliance, you can see this, a dentist should make this, and normally I do not give oral appliance just blindly. We have to do sleep endoscopy for those patients, and while they are asleep, we do jaw thrust. If that opens the airway and abolish the apnea, then this means an oral appliance is worth doing. Think about it, if you give this to a patient, the chance, it's a hit and miss. Without the sleep endoscopy, the patient could go and spend $2,000 to get this, and then it doesn't work. Overall, without the sleep endoscopy, we're talking about success rate of treatment of approximately 40 to 50%. And you can see there are screws on the side. Gradually, you can tighten these screws and push the lower jaw forward. That will push the palate and the tongue forward as well. That will reduce the chance of sleep apnea, and you have to wear it all the time. During sleep, it has side effects of temporomandibular joint, saliva on the pillows. Sometimes it gets dislodged. It causes teeth pain, so it has its own. The final thing, which is now there are trials on, is hypoglossal nerve stimulation. It is an electrode that is attached to the genioglossus muscle. The patient, you stop breathing. There's a sensor on the chest. The signal goes to the hypoglossal nerve. It pushes the tongue forward and contracts the muscles and relieves the apnea. It is very effective. That's all I need to talk about. Sorry, it's a quick presentation, but it gives you an insight. I didn't talk about surgery because surgery is, it has maybe about 60 or 70% success. Really, with you as general practitioners, the CPAP is the gold standard treatment, and there is no harm. We should try, actually, I try CPAP on everyone. Everyone gets offered CPAP because that's what usually is going to work, as long as the patient will put it on his face. Thank you.
Right. Right.
شكرا دكتور حيدر. الآن دكتور صافي ممكن share your slide and you can present your lecture.
What do I do? Do I close this or what?
I don't need to do anything.
Okay.
Dr. Safi will take over.
Dr.
Okay.
Issam, just maybe bring our colleagues' attention that they can write their questions in the chat.
They start writing the question, so I remind our colleagues to put their question from now on the chat room, so we can, at the end of the lecture of Dr. Safi, we can allow time to answer all the questions.
Yeah. Do you want to get the questions answered first, or shall I? Or at the end of the?
Yeah, at the end of both sessions, Doctor.
All right. Can you see the my share, my power?
Yes.
Okay. Thank you very much. I'll start now.
You can maximize the window if you want, the slide window, because we see your computer exactly as it is.
As it is, yeah, I'm not sure, but anyway,
yeah. All right, you present.
Yeah. Okay. Thank you very much for asking me to talk about common ENT problems today. Thanks to my close friend, Dr. Hayder, and of course, Dr. Ahmed Al-Rubayyi. I'm Dr. Safi Albekaa. I'm an ENT surgeon based in Canberra, and I've been in Canberra for more than 22 years. I will talk about the most common ENT problems. I'll start with the ears. And because I have interest in pediatric otolaryngology, probably I'll focus more on, let's say, pediatric ENT. First thing is I'm going to talk about is acute otitis media. And it's a more common problem in children than adults anyway. Usually present itself with pain in the ears. Usually it is bilateral and usually follows an earthy upper tract infection. The condition is most of the time easily treatable with a course of antibiotic, although there's a bit of controversy about that because also many of the acute otitis media in children can be self-limiting with symptomatic treatment. For example, a child with otalgia, give analgesia, fever, same thing. Treat the coryzal symptoms with saline nasal sprays. The importance of this matter comes from when it becomes recurrent. And recurrent acute otitis media is considered to be a problem when it exceeds 3 attacks per year. Most of the time, if that happens, it goes to a consequence or a complication of otitis media diffusion. Then that becomes a hearing problem. In children, it's a language developmental problem and other developmental problems that can affect children. I would like to focus to my good colleagues, please ask about airway problems in children who present to you with repeated attacks of acute otitis media or otitis media diffusion. I mean by that is chronic nasal obstruction, mouth breathing, snoring, which will lead us to talk about sleep disordered breathing in children. I'll just add to the absolutely great presentation of my good friend Hayder. Sleep apnea in children is a common problem and often missed, which is frustrating to us in the ENT specialty. I see many children almost on daily basis where the symptom of snoring, mouth breathing, restless sleep, a sweaty child, poor hearing, overactivity in younger children, and sleepiness and tiredness in older children, and some other problems, dental problems, chronic, all these symptoms, you cannot believe that. All these symptoms can be missed easily by the parents as they think it is normal. Who cares if the child snores, for example? And who cares if the child grinds the teeth? And there's a very strong link between a bruxism and airway obstruction. So this is something for many years I wanted to mention to my colleagues, the general practitioners. Please be aware that snoring can be just, of course, can be just a noise, but most of the time in children, it in fact indicates an airway obstruction. If you are in doubt, send the child to an X-ray of the lateral airway to show the blockage in the airway, the size of the adenoids and tonsils. If you are still in doubt about the significance of the matter, there are many centers in almost in every city in Australia that they do sleep studies in children, and it is a good tool of investigation, and it's not invasive. Coming back to the ears, acute otitis media, if it is recurrent, can cause scarring to the tympanic membranes, which will lead us to the second slide here, tympanosclerosis. This is a condition that often get confused with. I see many people with this condition referred to my clinic as cholecystoma, for example, because of the wide discoloration of the drum. Please get yourself familiar with a normal tympanic membrane picture and a bit of scar tissue. This picture that I'm showing you, which is the tympanosclerosis, is a benign condition that usually doesn't have any bad effect on the hearing. It doesn't mean much apart from discoloration of the drum. Most of the time indicates a past history of middle ear infections or grommets in the past, or the combination of the two. Middle ear fusion is a common ENT problem in children that requires, most of the time, requires surgical intervention in the form of middle ear ventilation tubes, as we call grommets. Because hearing is become compromised and affected, and for children is of great importance, more important than adults, because hearing clues is important part of the development, mental development, language development, social development, learning abilities can be all affected when you have a child with hearing loss. I will go to the other conditions in that affect the ears. We talk here about outer ear problems. Outer ear problems in the general practice, I believe the most common is, let's say, otitis externa, which can be classified to bacterial and fungal. The mainstay treatment for this condition, which is again, I see, I'm sorry to say that, it seems that I'm criticizing others. Of course not. The outer ear infections, I see it mistreated most of the time with systemic or oral antibiotics, while the main treatment is ear toilet and topical treatment, which is for bacterial infections. The most commonly used is Ciproxin HC ear drops. For fungal, again, it is ear toilet followed by antifungal preparation, like canestin solution. Sometimes we use leucocortin VO form. The problem with antibiotics, it does make the problem worse. And as you know, I mean, systemic antibiotics for fungal infections, it does make it worse. Plus the delay of the treatment and so on. To differentiate bacterial from fungal, bacterial is usually very painful condition. That's the main presentation, while fungal outer ear infections present itself as, most of the time, as hearing loss and a feeling of a blockage in the ears. We go to the next one. Exostosis is common in Australia. It comes usually from too much surfing and too much swimming, and it is simply the growth of bony lumps in the outer ear canals. People present either with frequent wax impaction that requires regular ear toilet, or present with recurrent attacks of outer ear infections. Most of the time, we treat the problem conservatively with a regular ear toilet, and in some cases, if this is not working, we go to surgical intervention, an operation called canalplasty, myetoplasty, to remove these growth of bony lumps. Traumatic perforation is not common. However, the most presenting symptom is patient tells you that I had an injury. Usually happens from a slap on the ear, any or a ball on the ear. Anything that brings high pressure of airflow suddenly to the eardrum can end up with a traumatic perforation. Again, I see sometimes mistreatment where antibiotics is given either systemically or topically. The best thing to do is just leave the ear dry, don't intervene, don't do much. Ask the patient to keep it dry, no swimming, and when they go to have a shower, an ear plug. Most of the time, this condition heals by itself. So, usually healing occurs in about 95% of cases within 6 to 8 weeks without intervention. The next thing that we're going to talk about is tympanic membrane perforations. We classify them into safe and unsafe. Safe is either there's no discharge, and most of the time people present with hearing loss, and we give them the two treatment options of either tympanoplasty, or what we call maryngoplasty, or a hearing aid, or we go to discharging ear, usually when there's exposure to water or after an ERT, and the treatment of choice is topical antibiotics / steroid drops. Again, the most commonly used is Ciproxin because it is not toxic to the inner ear apparatus. Unsafe ear is very important for my colleagues, general practitioners, to identify this and be aware that this condition is destructive and it is considered to be a potentially serious problem. The main features of cholesteatoma is you see the, for example, if you see this picture here, you see the eardrum looks intact and there is a pocket of a dirty looking pocket full with skin and keratin debris. Cholesteatoma can be quite destructive, can have a list of intracranial complications, and the treatment is almost always surgical. So please be aware of that. And if you are in doubt, a CT scan is a good idea. It will show us signs of erosion to the bony structures, the tegmen tympani, which is a thin plate of bone that separates the middle ear from the intracranial cavity. We did talk about acute otitis media diffusion. It's a common problem in children. Treatment of choice, the most common treatment of choice is middle ear ventilation tubes. You can see on this picture here the bubbles of air. You can see here the track. This is the grommet that we use to treat this condition. And you can see this middle ear is full with fluid. Middle ear fusion in adults, we do take it seriously as there's a potential of nasopharyngeal tumors that blocks the eustachian tubes and lead to fluid buildup in the middle ears. In our practices, we just when we see a patient with middle ear effusion in adults, we perform a nasoendoscopy to exclude this possibility. I will go to the nose now. Common rhinology problems is sinusitis, classified as acute or chronic. Acute is usually part of coryza, an upper respiratory infection. A patient presents with facial pain, headache, nasal discharge, loss of smell, fever, and the treatment is often a course of antibiotic, nasal wash, nasal steroid, nasal decongestant. The problem of this condition when it becomes recurrent, and again, recurrence means any number of acute sinusitis that exceed 4 attacks per year is considered to be a potential surgical problem, because that can also goes from frequent acute sinusitis to chronic sinusitis. Chronic sinusitis is something that we treat usually with a combination of nasal saline irrigation washout accompanied with nasal steroids. At the moment, we prefer nasal steroids that has an antihistamine in it. The best example is Demista and Rialtris. They are more superior than Nasonex and Rhinocort because they are purely made of steroid. We normally do advise patients to use nasal irrigation and steroids for at least 6 weeks, once or twice daily. And if the treatment fails, we go to surgical intervention in the form of endoscopic sinus surgery. We look for structural problems to correct in the same time, like septal deviations, turbinates, enlargements, allergic conditions, and in rare cases, people who are immune compromised. Nasal fractures, the general advice that we give is please wait for a few days for the soft tissue swelling to settle down before you finally able to assess the nasal bony fracture properly. And there are indications for sometimes CT scans. The CT scan is more superior than a plain X-ray. The main reason we do that is to make sure that there is no associated facial bony fractures if clinically indicated, and for medico-legal reasons. Treatment of choice, of course, if the deformity is obvious, is a close reduction of fractured nasal bones. Please look at the septum, if it is deviated or not, and look for complications. And that will include septal hematomas and septal abscesses. A septal abscess is potentially serious problem because that can lead to intracranial infections. And I've seen a few in my extensive experience, where the problem can be easily solved in the beginning, and it was left untreated, it was disastrous. I'm going to talk about some throat conditions, and I'm not sure if the time is okay or not, Dr. Ahmed Habibi.
Yeah, it's okay. A few minutes, few more minutes.
Few more minutes. I will go quickly through throat problems. Again, tonsillitis is a common general practice problem, either present itself with acute tonsillitis repeatedly, and when is the time to refer to an ENT surgeon? We say to our patients and colleagues is that if you get more than 4 attacks of acute tonsillitis in 1 year, and that goes to 2 consecutive years, it is an indication for tonsillectomy. If you have 3 attacks per year for 3 consecutive years, that's an indication for tonsillectomy, and so on. Sometimes we remove the tonsils because they are large and they can be causing obstruction, as Dr. Hayder indicated earlier. Tonsillar hypertrophy can be one of the reasons of sleep apnea, as well as sleep disordered breathing in children, which is usually associated with, in children, usually associated with adenoid hypertrophy. Treatment of choice, of course, if the criteria of repeated infections, obstruction, affecting sleep, affecting middle ear function, and so on, is surgical removal of the tonsils and adenoids. I will talk briefly about a common ENT problem I see almost every day. Globus pharyngeus, often missed as infection in the tonsils, or most of the time I see people after multiple courses of oral antibiotics. Globus pharyngeus is a condition caused by chronic muscle tension. The patient present either with a lump in the throat or a soreness in the throat that comes and goes without fever, without any other associated symptoms. So please be aware that globus can simply be caused by persistent or intermittent muscle tension that leads to muscular type sore throats. It's usually a diagnosis of exclusion, by, of course, looking at the throat, pharyngoscopy. Sometimes we do laryngoscopies, and of course CT scans, MRIs, and so on. It's a diagnosis of exclusion, but it's a common problem. It's a very common problem. As common as another problem, which I didn't mention when I talked about the ears, otalgia. Again, it could be misdiagnosed as outer or middle ear infections. Otalgia can be neuropathic. People can present with otalgia, ear pain, just because of disorder in the nervous system, the sensory nervous system, similar to, for example, migraine headache. There is no real specific reason for it. It can be also caused by bruxism, teeth grinding and clenching. Also, this is one of the things that can be often mistreated with antibiotics, and the actual reason is neurogenic. The last thing I'm going to talk to is hoarseness. Hoarseness, the principle that I would like to stress on is, if you have a patient who has hoarseness that is not going away, after 3 to 4 weeks, the patient will require laryngoscopy to exclude, again, common laryngeal problems, that is nodules, polyps. Of course, reflux can present with hoarseness, and of course, more importantly, carcinoma of the vocal cords and the larynx. And I thank you very much for your attention.
Thank you very much.
شكرا جزيلا دكتور صافي ودكتور حيدر، محاضرات قيمة. الآن نفتح المجال للأسئلة. أكو سؤال من أحمد ذو الفقار. I miss the success rate of oral appliance without sleep endoscopy. Can you mention that again?
It's approximately 40 to 50%. But if you do sleep endoscopy for those patients and you directly observe the opening of the airway and the stopping of the apneas upon the endoscopy and upon jaw thrust, you're talking about 90%. Otherwise, there's no need to prescribe the oral appliance blindly.
شكرا دكتور حيدر. هل اكو سؤال اخر؟ لان I can't see any question.
ممكن انا
دكتور احمد عندك سؤال؟
نعم. طبعا بالبدايه يا امتنان كبير للزميلين دكتور حيدر ودكتور صافي.
شكرا.
المحاضرات الشيقه جدا فعلا. انا كنت مشدود للحد اللي نسيت الوقت يعني حضرنا الوقت وانا ما ادري.
شكرا
انا
جزيلا.
بس السؤال اللي اول سؤال دكتور حيدر.
نعم.
دكتور الستيميوليشن اللي ذكرته هل هو الانسباير او هو الانسباير as an alternative for the CPAP?
The hypoglossal nerve stimulation, it's a device like the cochlear implant device. It's implanted in the chest. It's يعني at the moment Australia is trying to get it approved by the Medicare for people that can't tolerate the CPAP. There's a center that they are doing the research on it in Perth and in Adelaide. So it's implanted in the chest. A cable goes to the neck, under the skin of the neck. The hypoglossal nerve is the end of the cable is clipped on the hypoglossal nerve, and the sensor will send the signal the moment you stop breathing. So it is an implantable device as an alternative treatment when the CPAP. It costs approximately $30,000 to $40,000, just like the cochlear implant.
Right. I'm interested in obstructive sleep apnea for a variety of reasons, most of them related to my specialty, and I'll tell you more about it. But I read that the success rate of this device, the Inspire, which I imagine it like the permanent pacemaker for the heart. So it's implanted in the chest in an outpatient setting, right? The success rate is estimated around 80%.
Yes.
And it seems the rate of satisfaction is very high, even more than the CPAP.
It is a high rate, but because of the price of it at the moment, it's already in use in the United States. But here in Australia, there is significant restriction on it because of the cost. Probably it's going to become more available. Yes, because there is high satisfaction rate. But think about it, Doctor. Those patients, they've already tried the CPAP, they didn't like it. They probably went for surgery and it didn't work. And they tried the oral appliance, it didn't work. And they lost their license and they have multiple comorbidities. So this is almost, at the moment in Australia, it is the very last resort of treatment. So eventually, if it is going to work, it has to be quite satisfactory for the patient. But they have to be selected carefully, those patients.
Right. إذا أكو سؤال أحد من زملائنا سؤال يمكن دكتور أحمد الفقار عنده سؤال دكتور عصام.
أي نعم. السؤال هو how it's gonna work the hypoglossal stimulation implanted device, I mean.
Yeah, it works through the sensation that the chest movement, the normal respiratory rhythm have stopped, and there is disturbance. There is pausing of the breathing, or there is alteration or change of the regular respiratory pattern that has established in the beginning of your sleep. Yeah, when you fall asleep, you're not going to go to sleep apnea after 5 seconds. You're going to go into regular sleep with regular breathing, and then there will be change of the pattern of your breathing, and this device is programmed to sense that change of the breathing and the interruption of the respiratory movement or the alteration of respiratory movement. It's not interruption always, because with the central apnea it is interruption. With obstructive apnea, you could still be struggling to overcome the obstruction, and that's when it senses the change of respiratory movement and it sends the signal to the tongue, to the hypoglossal, to the tongue to contract it and push it forward.
هناك شكر من Dr. Awsal Al-Musawi for both great presentations.
شكرا جزيلا.
ممكن أنا عندي تعقيب هنا بعد أسئلتي الدكتور حيدر وبعدين أجي الدكتور صافي. For me, because I'm a gastroenterologist, endoscopist, but also we work with the heart of general physician. Now, for a while, I'm convinced that obstructive sleep apnea is on the list of differential diagnoses of, first of all, uncontrolled reflux, particularly with the night manifestation. So sometimes the uncontrolled reflux is not related to the cardiopharyngeal junction and the loose sphincter. It's also related to other factors like gastric dysmotility and other factors. Among them is the obstructive sleep apnea. So if I exclude all factors in the uncontrolled reflux on full medical treatment, I go to check for the obstructive sleep apnea. That's one. Two, lethargy, tiredness, and headache without any specific cause, I go also for a referral for obstructive sleep apnea. So the spectrum is wide in medicine, is wide. Uncontrolled hypertension, for example, it ends also at one of the mechanism is the obstructive sleep apnea. هاي بس للعلم يعني. اكو سؤال اخر
دكتور؟ هو هسه يعني with time the rules for driving for obstructive sleep apnea patients is becoming more significant. يعني احنا in Australia we are probably a little bit behind. In the United States, about 4 years ago, anybody who is above the age of 40 and wants to go for commercial as a commercial driver license, if their weight is above 100, they have to go for a sleep study, mandatory sleep study, before they can go, before they can have a commercial license. And you know, with the Americans, like probably half of the United States, their body weight is more than 100. So like they are doing millions and millions of sleep studies, and they are using that new technology, the WatchPad device with the peripheral arterial tonometry. It's easy, it's quick, relatively cheap, you know, it's well tolerated, and it's quite yielding because the patient falls asleep very well and comfortably, and you're not wired, you know, and the result, and the machine self-reports. It generates a report, and that's it.
Excellent.
I will mention here a case was referred to me by a cardiologist. One of the diplomats here in Canberra, in his mid-40s, very intractable palpitation and arrhythmia that the cardiologist could not treat with all the measures, and then he thought it is because of the sleep apnea of that patient. I sent the patient to, he did have a sleep apnea, but then during the investigation of the matter, we found that he had a carotid body tumor that was causing pressure on the carotid body and causing the palpitations. A very interesting case. Sometimes the interaction between the different specialties can certainly solve difficult problems. And no doubt, sleep apnea can have different ramification for different people.
دكتور صافي، أنا بالنسبة لي أكثر المرضى مالتي كارديولوجي وأسوي الهولتر reporting very common sleep apnea. When I do Holter reporting at night time, you can see some poses, heart rate variability. I send them for that. Refractory hypertension. Any patient with arrhythmias, particularly atrial fibrillation, and they get poses at night, we usually find it's sleep apnea.
Yes.
We don't put pacemaker before we exclude that.
Absolutely.
So it's very common. Mental health, depression, also very common. We can see it.
Yes. With the sleep apnea, you mean?
With the sleep apnea. So
yes, of course.
Their combination, it's become refractory hypertension, depression, arrhythmia, angina, and overweight, which is a common, the main driver is sleep apnea, or maybe the obesity causes the same problem.
Yeah.
So it's very common. I get like I refer a lot, and most of the time is positive. And the problem is that these people come to me many years. They have short neck, they have obesity, they have snoring, but nobody asks this simple question. I usually do Epworth sleepiness scale. They're very simple in part of any interview I do with my patient. If they have hypertension or arrhythmias, I usually do that as a routine, and very commonly to be high. So maybe the GP can benefit from this part. There's a question about how does a patient recognize they have sleep apnea, as the presentation is so vague and non-specific. When do they should seek specialist advice?
Most of the patients, Victor, when they tell you, I wake myself up, I will be asleep, and suddenly, like I startle during my sleep, and I wake myself up. Or I hear the term they describe, I hear my own snoring, or I hear they call it a snort, like a big snort. And that's the moment when their breathing resumes. That's not the moment of the apnea, that's the moment when the breathing starts again. So patients usually, or they come and they say, I'm tired. People are now becoming very much, there's a lot of awareness about sleep apnea. They tell you, I'm tired, I'm sleepy, or my partner hears me snoring, or the partner think that I stop breathing, or I wake myself up, or I'm hear my own snoring. This is the usual description of the presentation, unless they are referred. And then when they talk to you as general practitioners and then I'm sure you'll recognize it as a sleep apnea.
And fatigue is very common. People, when they are fatigued and tired, they are seeking for a reason, and usually the problems start then. Of course, either that or the partner's complaints about loud snoring, and sometimes partners are really worried about the cessation of breathing. They see their partner gasping for air, stopping breathing, choking episodes. That's one common thing, and the other common is fatigue. I'm tired. I don't know why I'm tired. I went to my GP, I did this, I did that, and I just can't feel, I'm not feeling well. I'm starting to get depressed and anxious, and I can't do anything. I'm putting on weight and these kind of things.
Excellent. Actually, the most serious sign is the partner complaint, I think.
Yes, that's right. And fatigue is a common problem. It's people just want to have a solution to this. They want to feel energetic. They want to feel normal. And usually the investigation starts with the sleep study, scans, nasal endoscopy, and so on.
Yep. Dr. The question about the types of CPAP. I heard that they are much more coincided, and they are smaller than those big machines that remind us with the ventilators in intensive care.
Yeah. The CPAP machines, mainly we have the CPAP, which is the continuous positive airway pressure, and we have the APAP. And then you have, of course, the BiPAP. The BiPAP is mostly for central apnea and for people that retain carbon dioxide. Usually it's used by respiratory physicians. But the CPAP itself, the common one that we use now, and it's covered by, for some people, let's say Department of Veteran Affairs, it's the APAP, the automatic positive airway pressure machine. The basic principle of it, it's all the same and it haven't changed. They are all producing a pillow of air inside the airway to stent the airway open and allow breathing. You have different things that the machines can do, as I call it, the luxury. The luxury could be humidifier, could be warm dehumidifier, could be warm the tubes, that you get warm air. Some of them, they give you a screen that, they have a screen that communicates, actually a screen that you can see in the morning, and you see how many apneic episodes you had, how much air, how many liters of air per minute, how much air leak you had. Some of them you can control them from distance. Some of them it communicates with your phone. It sends you a report to your phone. These are the expensive specifications that you can add to a CPAP machine, or you can buy. It's like when you buy a car, which is expensive, or you buy, you know, a basic car, but it will also take you where you want to go. So the CPAP machines now, mainly the APAP, which is the automatic positive airway pressure machines, they are different to brands. The common brands that we have, the best one, of course, is the ResMed, which and then the Philips Respironics, Fisher and Paykel, and BMC. You know, there are different brands, but all they have the basic. They share the basic principle of the air pillow production.
Thank you.
الأخ عماد عنده سؤال أو تعقيب، تفضل أستاذ عماد.
I would like to thank you, Dr. Issam, for coordinating this seminar or webinar. Thank you to Dr. Safi and Dr. Hayder. And my question goes to Dr. Hayder. Just like a curiosity, by curiosity, you spoke about to avoid some drinks like alcohol, maybe coffee, something like that. It's any foods to avoid as well during our day or before to go to bed?
Not really. You know, the food, okay, generally speaking, this is a general principle. You don't eat before you go to bed. You want about 3 or 4 hours, at least, you know, 4 hours before going to bed. But no, there is no food type that I know. Generally, anything that can have, you know, I don't really think it's related to food. Definitely, the alcohol has a depressive effect, and the alcohol also makes people snore a lot. And when they wake up repeatedly. It confounds the history of the sleep apnea, because people, when they drink alcohol, the alcohol has a diuretic effect, especially the beer. They wake up multiple times at night to go to the toilet anyway. But I mentioned also that one of the signs of the strain of the heart of the sleep with the sleep apnea is having to go to the toilet repeatedly. But no, I'm not aware of the type of food that could make it, or certain drinks. I don't know if Safi knows. You know any type of food?
No, there's no.
I heard maybe that cheese is not recommended, especially the country cheese.
Why?
I don't know, because it's rich on many things affecting or something like that.
No. Now, if we come to talk about alcohol effect, alcohol has a depressing effect on the respiratory system, and it also has an effect to relax the muscles. And we all know that an important part of sleep apnea is the tongue base, or the muscles of the tongue. It becomes so relaxed that can fall backwards and can cause the airway blockage. And that is why Dr. Hayder was talking about the mandibular advanced splint as an important part of treatment. So muscle relaxant effect and depressing effect on the respiratory system. Food, yes, maybe if someone has bad reflux, you go to have a big meal, you go to sleep, you get some edema and some swelling in the laryngeal inlet and so on. This can be, of course, also a bad effect. But a specific type of food, I'm certainly not aware of that.
Yeah, Dr. Anna, while you are talking, I searched it. Now, there's no evidence, but it says in general high calorie diet and diet high in saturated fats. Drinks are soda and other sugary foods. I don't know if there's evidence on this or not. Yeah, so I'm not sure.
But also that indicates that it is the effect of reflux more than the direct effect of the food.
Maybe, yeah. But the last question, just like connecting to that one, when we're talking about treated the people with sleep apnea with medication, is any vitamins as well recommended for sleep apnea?
Not that I know of, no. With medications, when they treat the sleep apnea with medications, you're probably talking about certain sleep disorders, like they treat them with respiratory stimulants, or for example with a sleep depressant, respiratory or let's say sleep inhibitors, for example, people with narcolepsy. Yeah, so I'm not that familiar with those medications. Yes, usually the sleep physicians with people that have narcolepsy, cataplexy, all these names of rare sleep disorders, they can treat them with medications.
دكتور حيدر ممكن العلاقة الويت loss lifestyle is very important part in the management of sleep apnea rather than selective vitamins. Yeah, maybe this is important too.
Yeah, absolutely. The weight loss actually particularly has a role in, of course, it always has a role in all types of sleep apnea, but when you have somebody with moderate sleep apnea, it can go to mild if you lose 10% of the body weight. It can bring you from one category to a lower category of apnea. Or for example, mild sleep apnea, it can go to normal if you lose 10% of your body weight.
Yeah, the reason I ask that, because before we get into this webinar, I've got a friend of mine who suffer from sleep apnea, and some of the recommendation to take vitamin C. I said I will ask.
Okay, I'm not familiar with this.
Oh, thank you.
People have all different sorts of different ideas based on nothing.
Yep. Thank you.
ممكن إذا أنا بس يعني I try to highlight 3 common topics with the crossover with the ENT, and these are directed to Dr. Safi to comment on. We come across as a gastroenterologist, endoscopist, and ENT issues through at least 3 conditions. One of them is the laryngeal symptoms, throat clearance, hoarseness of voice, and what do you call it, the erythema of the vocal cord. And we are here in a clash with you, Mike. I should tell you that most of the cases you send us with this indication pointing out to reflux are probably not related to reflux. And I'm not quite sure how evidence-based this link between reflux and all these conditions. Usually reflux relate to typical symptoms, and in fact we diagnose reflux through symptoms more specifically than even the endoscopy. So if the patient has no reflux, then it's unlikely or less likely for them to have the other symptoms like throat clearing and other things that might be related to the sinusitis. This is one. Secondly is the H. pylori and sinusitis. We do have some evidence that H. pylori, and this is for our GP colleagues also, H. pylori have some role in sinusitis. I don't know about the exact link. Likewise for the reflux. And the third one, we are both on the same line, which is the globus pharyngeus or the globus. Sometimes the patient is referred to us to do endoscopy because of this feeling of a lump or in the thing there. So yeah, what's your comment?
So when I started as a young ENT surgeon, I was in belief that GORD has a long list of links to other ENT problems. As I'm traveling with my career, which now is more than 30 years, I don't believe that many of these things that link to GORD is existing. For example, let's say your first example, which is the throat clearing and reflux. In my experience, most of the time, it is caused by a chronic muscle tension disorder, which we talked about, which is a globus. A globus is a variety of symptoms. One of them is a feeling of lump in the throat. And when you feel a lump in the throat, what do? You don't like it. It gives you an irritation. So you go, and this throat clearing will only add to the problem, because this action that you make, if when we do, for example, laryngoscopy and ask people to do the throat clearing, you will see the mucosal wave of the vocal cords becomes enormous, becomes so traumatizing to the vocal cords. And then that will, of course, that will cause even more feeling of lump in the throat, will encourage the patient to do more throat clearing, become a vicious cycle. And I see many patients who were diagnosed with GORD, let's say because of globus or throat clearing, and they were given a PPI, for a prolonged period of time, no benefit, no difference, no effect. I rely this to, we live, we truly, I can present a lecture of 1 hour with psychosomatic symptoms of ENT or in ENT. I mentioned otalgia, I mentioned the globus. We see many people with facial migraine, which is not related to sinusitis, and so on. So to answer your question in simple way, I think GORD or reflux has been over the years blamed for many symptoms and medical conditions. And they could be, 1 in 100 patients could have chronic sinusitis caused by reflux, but the great majority is not. And then GORD is blamed for that. And the evidence on that is we see many people who've been treated with reflux and they still continue to be symptomatic from the ENT point of view.
Dr. Ahmed, the background of the sinusitis, initially it started in 2002 with a paper that was published in the Lancet, so in a quite reputable journal. Somebody, while putting grommets in the ear, decided to suck the fluid and check it for pepsin. And they found that it has high concentration, 85%, big number, of the patients that had grommets, they had positive pepsin in their high concentration of pepsin in their middle ears. That triggered the thinking or the thought that the acid goes that high. But when you probably can answer that question even better than me. When you are doing esophageal manometry or a pH study, and if the probe is sitting above the cricopharyngeus, how many of those patients you would see, or you would see the impedance, not the manometry, sorry, the pH study and the impedance, how many of those patients the probe above the pharynx or in the above the esophagus would show that there is reflux, or the reflux is going that high? I don't know. I'm sure you see those patients more than me when you send them for combined pH study and impedance. Dr. Ahmed?
To all general practitioners, the presence of acid doesn't mean a cause-result relation. It doesn't mean that. And to prove that, you put the patient on a double dose proton pump inhibitors for 6 weeks, right? If there is a response, then this causation relation you establish. But after 6 weeks of regular PPI, if there is no response in terms of throat clearing, etc., this means that there should be another mechanism. It's very enjoyable keep discussing, guys. Dr. Issam, if you allow me to thank our colleagues again, Dr. Hayder and Dr. Safi. In fact, this is one of our best presentations there. And I should say that during the arrangement of this session, Dr. Safi and Dr. Hayder were very easy to work. They were ready, they were very flexible, and they accommodate all the changes we had. So
Shukran jazeelan.
Thank for them. Really, we thank. I just want to mention that our next session mostly will be on autism. And I would like also to mention that I will leave in probably 20 minutes to join the Victoria branch of our IAMA association and arranging the next medical conference. So the next medical conference arranged by our Iraqi Australasian Medical Association will be in Melbourne. So that will be another event, and we hope that we can pass a lot of update for you. Thank you again very much. Thank you, Dr. Issam, for the platform and for unwell today. But thanks for your help. Thank you.
شكرا جزيلا. شكرا للجميع.
شكرا
ممنونين. شكرا إن شاء الله بخير. مع ألف سلامة.
باي صافي.
حبيبي مع السلامة حيدر. الله يحييك. مع السلامة.